Windows war. After a long time, I prepared something in the Apple thing. Somebody I didn't know. Anyway, good afternoon and sorry for the voice. I will try to go near the mic. I will try to practically speak on this topic on diabetes, which is a very common problem. The previous talk was aging. Aging and osteoporosis are, as you know, closely related. The talk previous to that was on organophosphates, endocrine disruptor causing diabetes. There has been a lot of work on this. So the first 5 minutes I will speak on the general approach to bone health, osteoporosis from a physician's point of view, giving you some practical thoughts on that. Then try to link diabetes somewhere there so that in your diabetic patient, can you do something better for their bones also? This definition of osteoporosis was defined long time back. Some of the words used are research oriented. For example, microarchitectural deterioration of bone tissue cannot be assessed clinically, but later the WHO came up and the NIH consensus conference with a new term which is more appealing to practitioners like us, which is bone strength. This bone strength is the term which includes not only the bone density for which we have a gadget to assess, but it should also include what is called quality of the bone. I'll give you the principles or the approach of how we assess these two clinically. Before that, this slide will tell you that all of us sitting here who are probably 30, 40 plus minimum, we all have achieved our peak bone mass roughly around the age of 30, provided you had normal puberty, normal nutritional health in your childhood. So such a normal healthy child will achieve the maximum bone mass around 30. அதுக்கப்புறம் எல்லாம் deterioration தான். After 30, slowly the bone mass will come down in all of us. And I have my own reservations on the previous talk by Dr. Matthew John where you can't do anything about this. And in females, unfortunately, the physiology itself dictates them to go through menopause rapidly. The sex hormones come down in a rapid fashion, so there will be almost 7% bone loss in contrast to 1% bone loss per year in the first 2-3 years of menopause. After that, it will be a plateauing, and this is the background in which you should understand that when you look at somebody at the age of 50 and 60, the bone has undergone all this, and after 30, everything is a downward trend. So what you achieve at 30, so nalla investment mari. You should invest on bones well by 30, 35 max. Otherwise, at 60, suddenly giving all new fancy drugs is not going to improve your bones. This is the first point. So whenever you see, when I see a patient with a fracture at the age of 60, I tell, unga ponnukku illa unga pethikku dhaan sollum, that they should probably. But in India, what's happening between the age of 20 to 30, generally speaking, they get married. The demand on bones in calcium and vitamin D metabolism during pregnancy, during lactation, 2 to 3 children in that 10 years. Peak bone mass itself is low. And adukapram 60 adu innum low. That's what we face, and this has to be kept in mind. Idhula kurukka diabetes vera vanda, you can imagine how complex the things will become. So we'll go to ultimately the goal of treatment. Even in diabetes, I'm sure all of you senior physicians sitting here, diabetes is not just controlling glucose. You want to have a comprehensive metabolic control of dyslipidemia, blood pressure, ultimately cardiac prevention. Same way, in osteoporosis, reducing fracture is the aim, not improving the bone density by a DEXA scan machine reporting somewhere. That will be one guidance for us, but that will not be the aim of. So therapies or actions which will help us prevent or reduce fracture is what you should think about when you think of bones. In this background, because the quality of bone and the microarchitecture cannot be assessed that easily in the bedside or by any simple gadget, this arbitrary definition of bone density based definition of osteoporosis came into vogue way back in 1994. One senior endocrinologist spoke on this a long time back, telling that only 8 people met in Moscow in some hotel like this, and these numbers were derived. just to tell you. So, and where data is available, the population level of fracture at what level of bone density it fractures is the criteria for all this. And roughly, as you know, we compare the bone density assessed by an X-ray machine computerized evaluation, which is called DEXA scan machine, with the young people, and that's called T-score. T-score is a statistical score. And there are a lot of fallacies because it is X-ray based, aortic calcification, osteophytes, kyphoscoliosis, all of them will alter the T-score independent of real osteoporosis. So you should keep all these in mind when you are interpreting this. So with all this in the background, it is easy to understand that BMD alone is probably not enough to diagnose osteoporosis. It is even more intriguing, these data, where most of the people who fracture do not have minus 2.5 or lower BMD. Most of them are actually in the osteopenic range. Mind you, these kind of data are not accident or that kind of high velocity trauma data. These are all trivial fractures. When we say trivial, falling from standing height. Slipping, like bathroom la vadikku vanda ingathla indha mari edathla da maximum vadikku viduvanga. These are all the things which those most of the people will be in the osteopenic range, which means by density they are okay, but they are fracturing. That means you should think beyond this just density. And I have already mentioned, when the easily measurable part of bone quality is actually the bone strength is this, because we don't have any other thing, but so many other things also contribute. Tissue properties, mineralization, collagen crosslinks, micro damage. Even without going into diabetes further, I can just tell you, you know how vascular aging occurs in diabetes. Same way, all the collagen, proteins, etc., they also get glycosylated. Advanced glycation end products and all the abnormal crosslinks can happen in the bone. Bones also have capillaries. Ultimately, it is a vital, dynamic, living organ. Bone is not a static tissue. Microvasculature inside the bone will undergo same kind of changes which you will see in the retina or in the kidney. So it is not rocket science to understand that bones may get affected more in a diabetic. How much is it clinically relevant, etc., we will discuss further. Till now I discussed only bone strength and the components of that, which is density and quality. But please remember, ultimately, even a flimsy glass will break only if it falls down. Fall prevention is also part of any osteoporotic care. So in diabetic patients, you understand vision problem, neuropathy, motor as well as sensory, stroke. You have n number of reasons why a diabetic patient may fall more than other muscle, diabetic myopathy. So on one side you have hormonal issues, on the other side you have fall related issues also. So we have to think not just by bone density, but please think about assessing the patient holistically, and bone density is only one component of assessment of bone health of a patient. In this background only, Dr. Canis and his group from Sheffield University brought up this beautiful concept of FRAX, which is Fracture Risk Assessment Score, which is freely available in the net. These 7 or 8 standard conventional risk factors for osteoporosis have to be fed in there. One good point in this is, if you go into this website and click on the calculation tool, you will get India today. And this data is there for the last 7 to 8 years. A lot of statistical information. It will give you the osteoporotic risk, fracture risk over the next 10 years, both hip and any other major osteoporotic fracture. This is very important. This is like saying, CV risk score. If somebody has diabetes with blood pressure, with lipid, with obesity, with family history, with a CRP, with, if you have 4 or 5 parameters more, the risk is more. Same way, if the same patient has not only a low BMI, on steroids, has another inflammatory condition like rheumatoid, family history of fracture, that patient is at higher risk. All these are taken into consideration. Unfortunately, this also has a lot of problems, but this brought in the concept of seeing bone-related problem in a medical fashion, rather than just getting a BMD minus 2.8, so I'm going to treat. That's not the idea of this whole lecture as well as. So I'm going to link diabetes now, you will come to it. So what they did is, in non-diabetic patients, this is the best criteria even followed in primary care level in the US. Generic bisphosphonates are indicated if somebody's FRAC score is more than 3% for hip fracture and more than 20% for the major osteoporotic fracture. This is used in the bedside. There are apps now. You can just feed in your cell phone and it will give you immediately. This is not difficult. Only thing is you take the proper history. Anybody taking more than 3 months of steroids, prednisolone more than at least 5 milligram per day, current smoking, current alcohol, family history of hip fracture, all these kind of things are easy to obtain if you take. So ultimately again it comes back to our MBBS teaching, no? Good history taking, proper noting down, then that's all. If you don't have these FRACs, at least write these 7-8 risk factors in your file. Tick, this patient has more than 4-5 things, so more possibility of this. This is non-diabetic patients itself, these are all the risk things. So this will lead to a paradigm change in your approach, where initially it is a DEXA T-score based treatment. Today we don't go by treatment. The vertical line has changed into horizontal, where it is more based on fracture possibility. So even a 80-year-old patient with a minus 2.5 sometimes will not be treated if you follow this rule. So again comes holistic general medicine approach. Secondary causes of osteoporosis are too many. You can see the number of it. These conditions are not just like your rheumatoid means immediately steroid will come to your mind. Rheumatoid arthritis is high risk for osteoporosis independent of steroid use. Same way if you see here other conditions like myeloma, etc. So those things have to be kept in mind. Thyroid conditions, whether diabetes is to be included or not, is a good question. Lot of data is coming up in the last 10 years. There are a lot of modifications getting happened in the FRAC score, and that I will allude to in the next 10 minutes quickly. Please remember our patients. Today there is universal proton pump inhibitor use. Every other patient is on proton pump inhibitor, and there are a lot of risks associated with it. Absorption of calcium, absorption of nutrients. Glucocorticoid, excess thyroxine, two important anti-diabetic drugs, strong association with osteoporosis. Glitazones and SGLT2 inhibitor, unfortunately, canagliflozin has a lot of data on that. It does not mean that immediately you will jump and stop everything, but suppose in a postmenopausal lady, already she has had a fracture, and in that patient I am going to give you a glitazone or something, that at least you can avoid. This is the idea of knowing all this. It's not like you should not use SGLT2 at all in your patient. That's not the idea of this. Think about the other risk factors in this patient, and in that patient, you one more adding fuel to the fire need not be done. So please remember these drugs are directly adverse impact on bone. These drugs have to be avoided. Coupled to all of this, another problem is the rampant vitamin D deficiency. That's not the topic for today, but just remember that supplement vitamin D and calcium adequately in your patients, especially diabetics, because more data will come up now. So in general, a patient non-diabetic also, the T-score will be a guidance, but look into all clinical factors, get a FRAC score, estimate vitamin D, rule out secondary causes clinically, and then decide whether this patient should be on any anti-osteoporotic agent. This is what should be done. This will take extra 10-15 minutes on every patient, provided they give good history. Now comes, where does diabetes link into this? This is a very important slide to understand how diabetes is complicating the thing. You see here in this slide, this is non-diabetic curve. This is diabetic patients without insulin and on insulin. The red one is on insulin, blue is on insulin. This is without insulin. You see here, at any level of femoral BMD, diabetic patients fracture higher. Two inverse association. At any diabetic patient fracturing, their BMD is higher than a non-diabetic person. And any patient who has normal BMD fracturing, both are happening in this diabetic patient. This is like saying, I was wondering when I was going through this data, Hafner said, no, diabetic patients equivalent to cardiovascular risk. Same way, I think diabetic patient uncontrolled, long-standing with few other, they are equivalent to already one fracture probably. And this has been already proposed in the fracture. It is not only related to this duration of diabetes and a certain anti-diabetic use, they also have higher risk of fracture, both hip and major risk. But why hip? Because hip fracture patients, mortality is 20% in the next 1 year. Very high risk of other morbidities. So in ACCORD study, as you all know, they analyzed sub-analysis and one of them was fracture, though statistically not significant, numerically it was higher. What are the key points in diabetes and fracture? I gave you a background of how we approach osteoporosis. I have deliberately avoided discussing much on type 1 because type 1 diabetes, they are young children starting with diabetes. They don't achieve their peak bone mass, which I showed you initially. So they are at very high risk for osteoporosis and fracture. So a type 1 diabetic living for 20, 30 years at the age of 40, 50, the risk of fracture is high. It's an accepted risk factor. It's a known secondary cause. In type 2 diabetes, the previous concept was they are obese, so they will have extra estrogen, their bone density may be good. But even at good bone density, they are fracturing. I showed you that meta-analysis and those graphs. So any diabetic patient with fracture, they have higher BMD. Any patient with normal BMD also are fracturing. So the FRAC score is not helping here. So what are they proposing? To probably alter. Why are these happening? Multiple reasons I have already discussed. One component we can talk about is judicious use of some of these agents and addressing the other risk factors, especially traditional risk factors. I will not spoil your afternoon by going through all these complex pathways. Inflammatory pathways also play a role, and all other hormones controlling glucose also play a role in bone health. That's sufficient to know this. The bone markers, both the resorptive markers and formation markers, are in unfavorable terms in diabetes. That's the crux of all this. And very interestingly, top one, you see even insulin uses increased fracture risk because probably of hypoglycemia. Insulin is an anabolic hormone, so in general it should increase bone density. But the hypoglycemia and the risk associated with fall is probably making data show the adverse way in respect to insulin. So what is the clinical approach? I was just mentioning that FRAX is a very important tool, but FRAX does not include diabetes. They came up with this new computerized information on assessing the DEXA images with what is called trabecular bone score. You can see here the computer will give you a different assessment of the microarchitecture. I started off initially saying that microarchitecture is difficult to assess clinically. We go by history and FRAX score, but today you have one more computerized tool where you give, this is a 7 to 8 lakhs extra to be added to your DEXA scan. The cost of DEXA is already high, so somebody can argue that way. But this will give you a very useful information in our diabetic patients, and there is data to tell that this trabecular bone score in diabetic patients, even with normal BMD, helps in assessing their fracture better than a routine DEXA score with this guide. So the guidelines in 2015 by the International Society for Clinical Densitometry have included trabecular bone score in diabetic patients. So two propositions have been already made and coming up in review articles. I have put a provoking heading here to say, is diabetes, from the bone point of view at least, is a rheumatoid arthritis equivalent? Because rheumatoid arthritis is an independent risk factor for osteoporosis. Or if you are using femoral neck BMD in diabetic patients, you reduce it by 0.5. These two are already proposed in one article, and maybe in the near future they will come into work. So your T score, the FRAC score will change. So our threshold for treatment should be lower in a diabetic, and assessment should be more intense. So the principles of management are simple measures. It's ultimately prevention. Good glycemic control, judicious use of agents which may affect the bone, modest weight loss, exercise, weight-bearing exercise, very important, adequate calcium and vitamin D in Indian setting, smoking cessation, limiting alcohol. These are all general lifestyle measures which go in a long way in preventing not only diabetic complications but also bone health. And treat with bisphosphonates whenever the risk factor. This is because the treatment part is same as a non-diabetic patient on osteoporosis. But please remember, in diabetic patient, bone density will not be low. This will be one important message here. So the last slide, giving you the crux of all the points, including bone health discussion in your diabetic patients during their clinic visits, especially post-menopausal ladies who come with some family history is very important. Check BMD if they are affording and you have the access in all patients, especially type 1 diabetics, post-menopausal diabetic ladies, and males we have brought down from 70 to 60. And please remember, treating the BMD is not our aim. Fracture prevention, use agents which have been proven to reduce fracture. Anti-diabetic agents, especially SGLT2 and glitazones, are known to be associated with osteoporosis. Kindly use them judiciously in people at high risk. And I cannot overemphasize the importance of calcium and vitamin D supplementation at adequate doses. If time permits, we'll discuss more on that. The standard anti-osteoporotic treatment algorithm should be followed even in diabetic patients. Thank you very much for your kind attention.
Thanks, Shriram. We'll just take a few questions, if there are. I just had a small doubt. In premenopausal women, in spite of normal PTH levels, why is there this bone turnover very rapid in that premenopausal women? Any
Diabetic? No, not
in
diabetic.
diabetics.
Generally, what they have observed is the overall bone turnover is low in diabetics, not high. Post-menopause, the estrogen has a nice suppressive effect on the rapid turnover. So whatever literature I went through, the turnover is not high in diabetics, in premenopause. Post-menopausally, the turnover goes high.
The turnover is rapid. And it drops as you showed in that slide.
Yeah.
So which calcium supplement is preferred? Carbonate, citrate or tate?
Nothing different between diabetic and non-diabetic. Whatever I'm answering now is general for everybody. Calcium carbonate is the cheapest. Calcium to the tune of at least 8,000 to 1,500 milligram per day should be given in post-menopausal ladies. It should be ideally through food. There is beautiful data from New Zealand and Australia to suggest this. Tablets carry more risk of probably a slightly increased risk of renal stones, etc. So that fear of renal stone need not be there, but in India, it is a dual problem of vitamin D deficiency and calcium deficiency. The total intake from various studies from Vellore and South India, Tirupati, and so many studies are there from India itself to say that abysmally low calcium intake of 400, 500 milligram only per day, totally, and that too with our vegetarian diet containing phosphates and these phytates, which will prevent the calcium absorption, tea drinking, tan, everything will prevent. So ultimately you will absorb only 200 milligram or something, provided your vitamin D is normal. So ஒரு பக்கம் vitamin D low, இன்னொரு பக்கம் calcium intake low, அதோட absorption எல்லாம் prevention, where will you get calcium? So that's why we insist on giving at least 2 tablets of calcium carbonate per day, or you encourage them to take more dairy products and other things. உடனே நம்ம சுவாமிநாதன் வந்துருவாரு, எல்லாத்தையும் பெஸ்டிசைட் இருக்கு, நான் எந்த மில்கை குடிக்கிறது, மில்கை குடிச்சா ட்ரைக்ளிசரைட் ஏறிடும், சுகர் ஏறிடும், வெயிட் ஏறிடும். So you have to balance all these things and give the best advice to the patient. This is for general. But if your patient is on, as I mentioned, proton pump inhibitor and they have acid environment is less, calcium citrate is better than calcium carbonate.
Okay. Last question. Do we need to get on with DEXA scans in younger men as a routine health checkup? But I don't know what is men. Younger men in men?
Men, I would recommend not
because to. What is the age cutoff?
The topic being on diabetes, suppose somebody is more than 20 years diabetic, young age, like today we are seeing 30 to 40-year-old fellows coming with diabetes. Suppose that man comes at the age of 50, 55, some justification after all this can be given. But routine non-diabetic men don't do DEXA scan. 65, 70 is the US plus 70 plus only they recommend. General health check don't do. Diabetes. Very unfortunately, it is getting done.
Yes.
For various other reasons, we cannot talk here.
Okay.
Bone density should not be done routinely in general health check in men, unless you have a high risk patient. If somebody comes with fracture, you want to assess for monitoring purpose, that's different. Somebody is having I have a Klinefelter syndrome fellow who is coming on treatment. Some extra thing should be there. Secondary osteoporosis, you check. Otherwise, don't check. Is there anything I left? I'm sorry, I didn't.
No, that's fine. That's fine. Okay. I think we'll close the session. Thanks.
Thank you, sir.
Thank you.